sleep disorder. The best treatment options. Sleep apnea affects the way you breathe when you're sleeping. In untreated sleep apnea, breathing is briefly interrupted or becomes very shallow during sleep. These breathing pauses typically last between 10 to 20 seconds and can occur up to hundreds of times a night, jolting you out of your natural sleep rhythm. As a consequence, you spend more time in light sleep and less time in the deep, restorative sleep you need to be energetic, mentally sharp, and productive the next day. The chronic sleep deprivation that comes with sleep apnea results in daytime sleepiness, slow reflexes, poor concentration, and an increased risk of accidents. Sleep apnea can also lead to serious health problems over time, including diabetes, high blood pressure, heart disease, stroke, and weight gain. But with treatment you can control the symptoms, get your sleep back on track, and start enjoying being refreshed and alert every day. It can be tough to identify sleep apnea on your own, since the most prominent symptoms only occur when you're asleep. But you can get around this difficulty by asking a bed partner to observe your sleep habits, or by recording yourself during sleep. If pauses occur while you snore, and if choking or gasping follow the pauses, these are major signs that you have sleep apnea. Major signs and symptoms of sleep apnea: loud and chronic snoring almost every night, choking, snorting, or gasping during sleep, pauses in breathing, waking up at night feeling short of breath, daytime sleepiness and fatigue, no matter how much time you spend in bed. Other warning signs and symptoms of sleep apnea: waking up with a dry mouth or sore throat, insomnia or nighttime awakenings, going to the bathroom frequently during the night, forgetfulness and difficulty concentrating, uncharacteristic moodiness, irritability, or depression, morning headaches, restless or fitful sleep, impotence. Signs and symptoms of sleep apnea in children. While obstructive sleep apnea can be common in children, it's not always easy to recognize. In addition to continuous loud snoring, children with sleep apnea may adopt strange sleeping positions and suffer from bedwetting, excessive perspiration at night, or night terrors. If you suspect your child may have sleep apnea, consult a pediatrician who specializes in sleep disorders. Once obstructive sleep apnea is diagnosed, surgery to remove the child's tonsils or adenoids usually corrects the problem. Because obesity is a major predictive factor for OSA, weight reduction reduces the risk of OSA. The best data suggest that a 10% reduction in weight leads to a 26% reduction in the Respiratory Disturbance Index, RDI. Benefits of weight reduction in patients with SDB include the following: decreased RDI, lowered blood pressure, improved pulmonary function and arterial blood gas values, improved sleep structure and snoring, possible reduction of optimum CPAP pressure required. Weight gain is one of the most important determinants of relapse of OSA after surgical treatment. Although accomplishing and maintaining weight reduction are difficult, the results are extremely beneficial when patients can do so. The treatment approach to SDB is not complete if weight reduction is not addressed in patients who are obese. Mechanical measures include positive airway pressure with a CPAP or bilevel positive airway pressure, BiPAP, device and oral appliance, OA, therapy. CPAP is the standard treatment option for OSA and generally can reverse this condition quickly with the appropriate titration of devices. OAs are indicated for patients with mild to moderate OSA who prefer oral appliances to CPAP devices. Patients with mild to moderate OSA who do not respond to CPAP therapy. Patients with mild to moderate OSA in whom treatment attempts with CPAP devices fail. They should not be considered effective therapy for patients with severe OSA. Pharmacologic therapy is not part of primary treatment. No clinically useful drug therapy is currently available, except in certain cases of excessive sleepiness remaining after apparently successful treatment. From least invasive and effective to most invasive and effective, treatments can be summarized as follows. All patients should be offered nasal CPAP therapy first. In patients with mild to severe obstructive sleep apnea who refuse or reject nasal CPAP therapy, BiPAP therapy should be tried next. If this therapy fails or is rejected, OA therapy should be considered. OAS may be considered first-line therapy for patients with mild OSA, particularly if they are unwilling to try nasal CPAP therapy. All interventions to improve tolerance of CPAP therapy should be attempted prior to deciding that treatment has failed in a particular patient. Patients in whom non-invasive medical therapy, e.g., CPAP, BiPAP, OAS, fails should be offered surgical options. Patients should be made aware of the success rates for each surgical procedure. They should be informed that they might require more than one surgical procedure, some fairly extensive, to cure OSA. Refer patients only to centers that have personnel experienced in these special surgical techniques. Improving treatment adherence is important to the care of OSA patients. Whereas adherence in OSA patients is comparable to that in patients taking medications such as statins, a body of research on adherence seems to have been largely ignored and needs to be integrated into sleep medicine clinical practice. Studies showing how to improve CPAP adherence exist as well and should be integrated into a standard CPAP follow-up program to improve adherence. The same could be said for OA therapy to the degree that some of the methods and assessment are common to both treatments. Unlike CPAP, BiPAP treatment adherence, OA treatment adherence is not objectively measured. Therefore, studies comparing adherence between OA and CPAP, BiPAP therapy cannot be considered with confidence in the outcome. As when CPAP, BiPAP did not have objective adherence data, OA treatment adherence is probably lower than published values that have relied on patient or practitioner self-report. Sleep-related breathing disorder continuum. The concept of the sleep-related breathing disorder, SRBD, continuum, see pathophysiology, suggests that optimal OSA treatment must correct OSA, upper airway resistance syndrome, UARS, and snoring. If it does not eliminate all three problems, the symptoms and the pathophysiological process that was evident at the start of disease recur. Therefore, in the treatment of SRBD, CPAP corrects OSA first, ARS next, and snoring last. An unlikely occurrence is snoring being corrected before OSA or ARS. If this is thought to have occurred, then consideration should be given to the integrity of the snoring microphone. Consider whether snoring has been correctly interpreted on PSG during a CPAP titration. When a mask leak occurs, the noise may be transferred by the microphone to the PSG snore channel and may sound like snoring. One can determine the difference between snoring and a CPAP mask leak because snoring occurs at the point of peak inspiration and the beginning of expiration, mask leak occurs during expiration. Consider whether the patient has had upper airway, UA, corrective surgery. If pharyngeal tissue has been eliminated, snoring may not occur, but OSA can develop, so-called silent apnea. For milder cases of sleep apnea, your doctor may recommend only lifestyle changes, such as losing weight or quitting smoking. And if you have nasal allergies, your doctor will recommend treatment for your allergies. If these measures don't improve your signs and symptoms or if your apnea is moderate to severe, a number of other treatments are available.